Hello everyone, I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about polyhydramnios and oligohydramnios. So what we wanted to discuss today, the physiology of the amniotic fluid, the definition of both of them, the epidemiology, the etiology, the diagnosis, complications, differential diagnosis, and lastly the treatment of polyhydramnios and oligohydramnios. And we'll go through this lecture in comparison between both signs or both problems, polyhydramnios and oligohydramnios. So we'll take it in comparison. Okay, before we start to our lecture, we should know about the physiology of the amniotic fluid. Amniotic fluid, as you see in this picture, is essential for normal fetal growth and development. This amniotic fluid surrounding the baby gives protection from mechanical trauma, also antibacterial properties, aids in maintaining a sterile intrauterine environment. Also, this amniotic fluid is important for normal development of both lungs and limbs. So, what about this volume of amniotic fluid and its changes during the pregnancy? There is increase in amniotic fluid all over the pregnancy, linear increase until reaching the gestational age of 34 to 36 weeks, then become stable, and approximately this amniotic fluid around 400 milliliter. This stable at 36 weeks till reaching 40 weeks gestational age, then gradually decreasing after 40 weeks. So what is the source of this amniotic fluid? Maybe fetal or maternal. Fetal from excretion from the urine through the kidneys of the baby, and the respiratory secretions, skin and buccal secretions, or maternal origin, direct translation through the placenta. And that's why there is increase in amniotic fluid in some maternal disease like diabetes mellitus and heart failure, because there is increase in transudation in such conditions. Also, transudation from placenta and membranes from the fetal surface, also transudation from the umbilical cord. You should know that fetus produces 500 to 1,200 milliliter of urine per day, okay, and swallow approximately 760 milliliter of amniotic fluid daily. So the baby secrete through the urine about 500 to 1,200 milli and swallow 760 milliliter of amniotic fluid per day. So any problem as regard this, either secretion or swallow, in cases of congenital anomaly of the fetus, may cause polyhydramnios or oligohydramnios. So the baby, when there is congenital anomaly, that the baby cannot secrete urine because there is renal agenesis or urethral obstruction, okay, so there will be oligohydramnios. If the baby has a problem as regards the swallowing, that like oral or esophageal problem like esophageal atresia or duodenal atresia, so the baby cannot swallow, so there is polyhydramnios, okay. So what is the definition of polyhydramnios and oligohydramnios? Polyhydramnios is defined as pathological increase of amniotic fluid volume in pregnancy. And actually it is diagnosed by transabdominal ultrasound by two means, either single pocket measurement more than 8 centimeter, or amniotic fluid index by measuring the largest vertical diameter in 4 pockets in the abdomen. If this amniotic fluid index submission of these pockets more than 25 centimeter, it is polyhydramnios. On the other side, oligohydramnios is defined as decreased amniotic fluid volume for gestational age, and also confirmed by the transabdominal ultrasound through evaluation of the amniotic fluid, single pocket less than 2 centimeter in its vertical diameter, or through amniotic fluid index by summation of 4 pockets, 4 quadrant in the abdomen. If it was found less than 5 centimeter, it is oligohydramnios. As you see in this picture, this is polyhydramnios by ultrasound, and this is oligohydramnios. As regards the epidemiology, polyhydramnios occur in 1 to 2% of all pregnancies, and 60 to 70% are idiopathic with no identified underlying cause. 20% are due to congenital anomaly, congenital fetal anomaly. And you should know that idiopathic polyhydramnios is often a self-limiting condition. On the other side, oligohydramnios complicate 4.4% of all pregnancies at term. The incidence of oligohydramnios is less than 1% in preterm pregnancy. As you see in this picture, this is polyhydramnios with excess amount of amniotic fluid. This is oligohydramnios. You can see there is marked decrease in amniotic fluid, less than, even in a single pocket, you can't measure even 1 centimeter. Okay? So what is the etiology of polyhydramnios? Idiopathic is the most common cause, constitute about 60%. Fetal causes like multiple pregnancy in monozygotic twin transfusion syndrome. Fetal anomalies like CNS malformation as anencephaly and the spina bifida because of increased CSF in the amniotic fluid, and irritation of the meninges because it is exposed, so there is more increase in secretion in the amniotic fluid. Also, what is very important is GIT abnormality like esophageal atresia or duodenal atresia, chromosomal abnormalities, also maternal causes like diabetes mellitus with pregnancy, either diabetes before pregnancy or gestational diabetes, RH isoimmunization, and severe generalized edema. Placental causes like chorioangioma of the placenta. On the other side, the etiology of oligohydramnios include fetal malformation. What is very important here is renal agenesis and urinary tract obstruction. This is really very important because there is no secretion of urine. That's why the amniotic fluid decreases, because one of the sources of amniotic fluid is secretion of urine by the fetus. Also, another anomaly like tracheoesophageal fistula. Other causes like chronic leakage from membrane defect or following amniocentesis, premature rupture of membrane, severe fetal growth retardation, placental insufficiency, abruptio placentae, post-term pregnancy, and the chromosomal abnormalities. What is the clinical presentation of polyhydramnios and oligohydramnios? As regards polyhydramnios may be acute or chronic. What is the difference? Acute, there is sudden onset of large amount of fluid accumulate in few days, and this may be life-threatening because it causes pressure symptoms and severe dyspnea may occur. The abdomen is tense and tender and painful. Fetal parts and the fetal heart sound cannot be elicited. Locally, the cervix is pulled high up and effaced. While chronic hydramnios, it is of gradual onset. The amniotic fluid increases gradually. The patient feels discomfort in the abdomen, dyspnea, edema lower limb, and also there is edema in the vulva, abdominal wall, and oliguria. On the other side, oligohydramnios, thorough maternal and the family history is necessary to screen for conditions associated with oligohydramnios. So you should take a full history taking. And the medication use, because some drugs decrease the amniotic fluid, like non-steroidal anti-inflammatory drugs like endomesism. Also, we should concentrate on the past medical history, and if there is history of rupture of membrane and gush of water per vagina at any time during pregnancy. Then physical examination. In polyhydramnios, the abdomen is distended and the skin is tense and shiny. When you measure symphysis fundal height, you will find it more than 3 centimeters above the expected gestational age in case of polyhydramnios. Uterine enlargement with difficulty in palpating fetal parts because of this large amount of amniotic fluid cannot permit the feeling of the fetal parts by the examiner because the abdomen is tense and it is difficult to hear the fetal heart sound. Malpresentation is expected, of course, and the non-engagement, and you may diagnose multiple pregnancy is the cause of this polyhydramnios in one sac or in one sac or two sac. Preterm labor or premature rupture of membrane may result in cord prolapse. And this is very important, and this is a very emergency situation. On the other side, oligohydramnios, physical examination. Target physical examination to determine the etiology. Okay? Measure fundal height. You will find this less than expected gestational age. And this is one of the differential diagnosis of small for gestational age, oligohydramnios. Fetal parts felt easily because the amniotic fluid is decreased. Speculum examination and test for rupture membranes, like testing the pH, which is alkaline in case of amniotic fluid leakage. Nitrazine test, rupture of the fetal membrane test. As you see in this picture, this is a picture of how it looks the abdomen in case with polyhydramnios, diffuse abdominal enlargement, stretched skin, shiny, dilated veins, stria aggravated, as you see, and larger for gestational age. On the other side, oligohydramnios, the abdomen is smaller than the gestational age, and the fetal parts can be felt easily. So the symphysis fundal height here would be smaller than the gestational age. On the other side, symphysis fundal height would be larger than the gestational age. Okay. About the investigation, we said before that the diagnosis is confirmed by ultrasound, of course. Transabdominal ultrasound to measure single pocket. If it is more than 8 centimeters, it is polyhydramnios, and the amniotic fluid index if it is more than 25 centimeters, it is polyhydramnios. On the other side, oligohydramnios, single pocket less than 2 centimeter in vertical diameter, or amniotic fluid index less than 5 centimeter is oligohydramnios. What else? In case of polyhydramnios, a fetal ultrasound anatomy evaluation is very important, and you should screen for congenital anomalies, including oral, esophageal, tracheal, or intestinal deformities, central nervous system anomalies like anencephaly, or meningocele, cardiac septal defect, diaphragmatic hernia, any evidence of fetal hydrops by ultrasound with halos around the head, skin edema, anatomic findings consistent with trisomy, placental masses, and evaluation for fetal macrosomia. Also, we can do fetal karyotyping by doing amniocentesis, as in this picture, amniocentesis, to do fetal karyotyping. Basic laboratory studies like CBC, EBO, and the blood group, and the RH factor, antibody screen, glucose tolerance test, and toxoplasma, rubella, cytomegalovirus, and herpes simplex serology test. What about oligohydramnios? On the other side, ultrasound also is very important and targeted for structural anomalies in the fetus. As regard the urinary system, as we said before, it is very important, and assess fetal growth restriction and the markers of aneuploidy. Also, what is very important is umbilical artery Doppler to assess placental insufficiency, because placental insufficiency is one of the important causes of oligohydramnios. Non-stress test performed at least once per week until delivery. What is the complication? As regards polyhydramnios, there is higher incidence of preterm labor, premature rupture of membrane, cord prolapse, fetal demise, fetal macrosomia, breech presentation, cesarean delivery, and postpartum hemorrhage due to uterine distension. Fetal macrosomia, commonly seen in gestational diabetes, is an increased risk factor for neonatal hypoglycemia and the shoulder dystocia and the cephalopelvic disproportion requiring cesarean delivery. What about complication of oligohydramnios? There is increased risk of umbilical cord compression because decreased amount of amniotic fluid leads to umbilical cord compression. Also, meconium aspiration, cesarean delivery is increased, fetal heart rate deceleration, and the non-reactive fetal tracing. What is the prognosis? As regards polyhydramnios, the prognosis for mild idiopathic one is excellent, and the majority of cases resolve on their own. This is the mild idiopathic polyhydramnios. Maternal and fetal prognosis decrease with the severity of polyhydramnios because polyhydramnios affect the mother and the fetus. As regards this uterine distension cause dyspnea to the mother, discomfort, may precipitate early labor, and also premature rupture of membrane, malpresentation like breech presentation, umbilical cord prolapse, postpartum hemorrhage, fetal macrosomia, and the associated maternal diabetes. You should know that maternal and fetal prognosis decreases with the severity of polyhydramnios or become more worse. Okay? And also the earlier the polyhydramnios, the more severe and the more worse prognosis. and the acute one is more dangerous than the chronic one. What about oligohydramnios? On the other side, prognosis of oligohydramnios vary greatly depending on the underlying etiology and depending on also the gestational age at diagnosis and the severity of oligohydramnios. If you can continue the pregnancy or not, and what is the underlying etiology. So it is very important. Diagnosis of oligohydramnios during the second trimester is more likely to be associated with fetal anomalies, whereas diagnosis in the third trimester is more likely to be of unexplained origin. Again, in prognosis for polyhydramnios, severe and rapidly progressing polyhydramnios is an independent risk factor for perinatal mortality. Small for gestational age fetus that are found to have polyhydramnios have the worst prognosis. So, if we have a case with a small for gestational age baby, there is gross restriction in the baby, and at the same moment we have polyhydramnios, this is the worst prognosis at all in cases with polyhydramnios. Okay? The prognosis is directly correlated to the underlying cause of polyhydramnios. On the other side, oligohydramnios diagnosed in the second trimester, pulmonary hypoplasia is the most significant predictor of fetal mortality. And the mortality rate of second trimester oligohydramnios can be as high as 90%, with pulmonary hypoplasia accounting for 87%. So it is very dangerous one. That's why mid-trimester is the worst prognosis in oligohydramnios rather than third trimester oligohydramnios. Low amniotic fluid volume during second and the early third trimester also increase the risk of limb contractures and birth defects due to compression of the fetal parts. So, yes, early oligohydramnios in the mid-trimester and the early third trimester may be associated with limb contractures and birth defects due to compression of fetal parts, because one of the physiological function of the amniotic fluid is normal development of the fetal limbs. Imagine if this amniotic fluid is diminished, there will be birth defect, limb contractures, and so on. What is the differential diagnosis for case with polyhydramnios? We may have three categories. Differential diagnosis for rapid abdominal enlargement, differential diagnosis for dyspnea during pregnancy, differential diagnosis for edema of the extremities during pregnancy. For rapid enlargement of the abdomen, the other causes may be volume overload, like in cases of ascites, cirrhosis, congestive heart failure, renal failure, preeclampsia. Also chorioangioma, hematoma in the placenta in case of placental abruption. Also multiple gestation. As regard the causes of dyspnea may be pulmonary embolism, cardiac arrhythmia, chronic pulmonary conditions, infection, pregnancy-induced cardiomyopathy, musculoskeletal disorder. As regard the edema of the extremities may occur normally in normal pregnancy, also may occur in preeclampsia or pregnancy-induced hypertension, also in venous insufficiency and varicose vein and deep venous thrombosis. As regard differential diagnosis of oligohydramnios, this is the differential diagnosis of the underlying causes of oligohydramnios, actually, like maternal causes, fetal causes, and the placental causes, and the idiopathic one. Maternal causes like uteroplacental insufficiency in cases of chronic hypertension, vascular disease, thrombophilia, and preeclampsia, or due to drugs like angiotensin converting enzyme inhibitor, non-steroidal anti-inflammatory drugs, and cocaine use, all of them cause oligohydramnios. Maternal diabetes associated with complication as regard vascular disease. This is advanced stage of diabetes with vascular disease. Okay. Fetal causes for oligohydramnios like rupture of membrane account for 37% of cases. Genitourinary tract anomalies like renal agenesis, obstructive nephropathy, post-term pregnancies, chromosomal abnormalities, post-term pregnancy, fetal growth restriction, fetal demise. What are the placental causes? Placental causes include placental abruption, 20-to-1 transfusion syndrome. Lastly, the idiopathic or unexplained, and the majority of oligohydramnios cases are idiopathic, or what is meant by unexplained etiology. Okay, and this constitutes 50% of cases in third trimester. So idiopathic constitutes 50% of cases of oligohydramnios in third trimester. What is the treatment of polyhydramnios? The treatment varies based on the severity of polyhydramnios and the underlying cause. As we mentioned before, idiopathic and mild polyhydramnios spontaneously resolve, usually, okay, and rarely to require any treatment. Maternal fetal medicine consultation is recommended if we have a case with severe and symptomatic polyhydramnios. Why? For reductive amniocentesis and for treatment of 20-to-1 transfusion syndrome if present. Also, in presence of known fetal anomaly. So this is the specialty of maternal fetal medicine in these cases with polyhydramnios. Selective fetoscopic laser photocoagulation or laser therapy for 20-to-1 transfusion syndrome to ablate placental anastomosis. Endomesism, which is a prostaglandin synthase inhibitor, decrease amniotic fluid, and also can be used for another aim, which is a tocolytic drug in preterm labor. So can be used for both to decrease the amount of amniotic fluid and also as a tocolysis. The dose is 2 mg per kilogram per day and started at 24 weeks and discontinued at 35 weeks. And you should know that endomesism decreases fetal urine. That's why it is used for management of polyhydramnios, because it decreases fetal urine output. But on the other side, it has a complications, and very important. What is the complication of endomesism? Premature closure of ductus arteriosus, oligohydramnios, periventricular leukomalacia, and the necrotizing enterocolitis. Endomesism use in polyhydramnios should be restricted to severe cases of symptomatic polyhydramnios with preterm labor, and the Society of Maternal Fetal Medicine recommends against the use of endomesism solely to decrease amniotic fluid. So this recommendation say that we can use it only as a tocolytic and at the same time will decrease the amniotic fluid, but not only as a drug to decrease amniotic fluid. So if we need it as a tocolytic drug, we can use it. Okay. What is the time of delivery in case of polyhydramnios? It depends on the severity and the underlying congenital malformation and the presentation of preterm labor or premature rupture of membrane. In cases with mild and idiopathic polyhydramnios, there is no indication for induction of labor, and the mode of delivery should be based on the usual labor characteristics determined by maternal and fetal factors. Okay? In laboring patient with polyhydramnios, an ultrasound should be performed to determine fetal presentation. You can do external cephalic version in case of with breech presentation if there is no contraindication. Continuous fetal monitoring during labor is important. There is an associated risk for delayed first stage of labor due to overuterine distension and an increased rate of amniotomy. Cord prolapse risk is increased due to lack of fetal head engagement, which warrants cesarean delivery. Cesarean delivery risk increases with delayed labor progression and other factors including fetal macrosomia. Pediatric support should be available in neonates affected by polyhydramnios, as there is an increased incidence of transient tachypnea of the newborn, which results in increased ICU admission. Also, there is maternal risk of postpartum hemorrhage due to uterine overdistension. So all the measures to prevent postpartum hemorrhage and manage it if it occurs should be available. There is no consistent evidence to support bed rest to prevent complication associated with polyhydramnios, and the bed rest is associated with increased risk of venous thromboembolic disease during pregnancy. What about oligohydramnios? First, management of the underlying cause accordingly. Then prenatal management include weekly maximum vertical pocket measurements by ultrasound and non-stress test or biophysical profile at least once per week. And you should do serial assessment of fetal growth. Maternal hydration status also plays a vital role in management, particularly in cases of isolated oligohydramnios in third trimester, by giving the patient intravenous fluids and so on, and encourage the oral fluids also. The timing of delivery in cases of oligohydramnios, there is controversy surrounding the timing of delivery, but in cases of isolated oligohydramnios, the current recommendations support delivery at 37 weeks gestational age, assuming membrane remain intact. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.